Hello, my name is Dr. Douglas Weed of Genesis Health Institute. If you have peripheral neuropathy, you know how devastating it can be to the quality of your life. By the end of this lecture, you should learn more about it than you ever knew, and probably more than your doctor knows. You will be in a better position to make educated decisions that will assist you regarding your treatment options. You may have been told that there is nothing that can be done except to take medications to reduce your pain. This is untrue. By the end of my presentation, you will be happy to know that there are other, often very effective treatment options. In this talk, you will learn what peripheral neuropathy is, if you have it, what its causes are, what the standard treatment is and how well it works, what your treatment options are, and the research it supports its cutting-edge treatment program. Genesis Health Institute is a member of Neuropathy Treatment Centers of America, a group of doctors dedicated to providing the finest treatment for peripheral neuropathy. Neuropathy simply means pathology or disease involving nerves. Peripheral means that it involves the nerves outside of the brain and spinal cord, which together are called the central nervous system. There are different classifications of peripheral neuropathy. Some involve only one nerve and are called mononeuropathy. These tend to be caused by direct injury to the nerve or compression, like from a herniated disc. Sciatica is a common type of this condition, as a herniated disc usually causes it. This type of neuropathy is easy to diagnose. Today's talk will focus on polyneuropathy, or disease involving more than one nerve, and usually not caused by direct injury or compression. This is probably why you are listening to this lecture today. Other terms for it include length-dependent sensory motor polyneuropathy, small fiber sensory neuropathy, or autonomic neuropathy. This means that the condition generally affects the longest nerves first, or is length-dependent. The longest peripheral nerves are in your lower extremities and the longest in your big toe, so the feet are affected first. The other terms indicate that the motor nerves, or the ones that move your muscles, can be affected. Autonomic means that the nerves of your autonomic nervous system or the sympathetic parasympathetic nervous system are involved. This could cause lack of ability to sweat or reduced blood flow. Most commonly involved are your sensory nerves, which means that your ability to detect light touch, pinprick, cold, and hot are affected. Frequently, the neuropathy will be mixed, meaning that it involves motor, sensory, and or autonomic nerves. To summarize, peripheral neuropathy is damage or disease to nerves, which may affect sensation, movement, gland or organ function, and other aspects of health depending on the type of nerve involved. Obviously, you will want to know if you have peripheral neuropathy, and if it is of the type our program is designed to treat. There are 4 components to determining if you have it and if we can help you. They are the history of onset and progression of your condition, your signs and symptoms, findings on the neurological examination we will perform, and lab testing. To find out if you have peripheral neuropathy, we start with a thorough history. Some types are inherited. More commonly, one develops or acquires the condition. Taking your history will help elicit the underlying reasons why you have developed the condition. This lecture will focus mostly on the acquired reasons for developing peripheral neuropathy. Over the next 2 slides, see how many of the signs and symptoms of peripheral neuropathy apply to you. Keep track of how many apply. We'll talk about it at the end of these 2 slides. Do you have foot and or leg numbness, burning, cramping, prickling or tingling sensations, sharp, stabbing, or shooting pain? Do your feet feel asleep or have loss of sensation? Do you feel electric shock-like foot pain? Does it hurt when the sheets touch your feet? Do you have difficulty or are you unable to feel hot or cold with your feet while bathing? We'll move to the next slide, total the number that you have on this slide. Do you feel weak when you walk? Are your symptoms worse at night? Do your feet hurt when you walk? Can you sense your feet when you walk? Do you have poor balance? Is the skin on your feet dry, cracked, or ulcerated? Are your feet cold or discolored? Do you have constant dry eyes, mouth, or nose? Now total the number of positive signs and symptoms you have. If you have 3 or more positive responses, you may have peripheral neuropathy. The more you answered yes to, the more likely you are to have it. A thorough neurological evaluation is key in diagnosing the condition. Our evaluation is the most comprehensive you will ever have. It will include numerous orthopedic and neurological tests. We may refer you out for electrodiagnostic and vascular tests. We want to determine the underlying causes of your peripheral neuropathy. That is why, in our executive level peripheral neuropathy program, we perform the most comprehensive set of laboratory evaluations you will ever undergo. Were you to pay these tests yourself, they would cost more than our entire program. You will have a comprehensive wellness panel, 9 separate thyroid tests, a blood sugar evaluation that includes fasting glucose, HbA1c, and fasting insulin, tests for common autoimmune causes of peripheral neuropathy, a 74-test organic acid profile for metabolic testing, nitric oxide deficiency screen, a neurological autoimmune panel to see if you have autoantibodies against your own nerve tissue, tests to see if arsenic, mercury, or lead may be causing your condition, and tests for inflammatory causes, about 200 tests in all. It is critical to identify why you have peripheral neuropathy so we may treat it. We are going to spend some time discussing the known reasons, of which there are many. Your peripheral neuropathy is likely due to more than one cause, so we need to address them all. This is probably very different from what you have experienced before. You were probably told that your peripheral neuropathy is incurable, that it can only be treated with drugs, that it is due to diabetes, or that it was idiopathic, which is a fancy word for we really have no clue why you have it. Does this sound familiar? Common causes include autoimmune conditions, back surgery or back problems, circulatory problems, both peripheral artery disease and at the microcirculation level, diabetes and even pre-diabetes, hypothyroidism, gluten sensitivity and celiac disease, infectious causes, inflammation and oxidative stress, certain medications, metabolic reasons including mitochondriopathies, obesity, oxidative damage, vitamin deficiencies, and toxins such as alcohol, chemicals, chemotherapy, and heavy metals like lead, mercury, and arsenic. Let's briefly discuss each of the types of acquired peripheral neuropathy. A number of autoimmune conditions can cause peripheral neuropathy. Autoimmunity is when the body turns against itself and creates antibodies directed against self-tissue. Normally, antibodies are directed against foreign invaders such as bacteria and viruses. The body mistakenly thinks that its own tissue is an invader and attacks it. The autoimmune disease one gets depends on the type of tissue attacked. Nerve tissue itself can be attacked, damaging the nerves, or the inflammation caused by an autoimmune condition can damage the peripheral nerves. That is why we run lab tests to see if there is an autoimmune problem. Low back problems can cause or contribute to peripheral neuropathy. Any condition that compresses a nerve for a period of time damages the nerve. Since the small nerve endings in the skin of your feet are ultimately attached to the bigger nerve being compressed, they are ultimately also affected. Just like stepping on a hose far from its end causes less water to flow out of the hose, compressing a nerve proximally causes less flow to the distal parts. Nutrients, mitochondria, and blood flow can be affected. It can take 2 to 3 years for mitochondria to travel the 3 to 4 feet down to the end of the nerve from the nerve body where they are made. Compression can affect this flow. We will discuss the critical role mitochondria play in greater depth in another slide. Nerve tissue is very active metabolically. For example, the brain only weighs about 3 pounds, but depending on how hard you are thinking, it takes 20 to 30% of the entire energy output of the body to run properly. An analogy is a computer. The majority of the power is needed by the computer's brain, in this case integrated circuitry. The screen, mouse, and keyboard only take a little energy to function. So nerve tissue requires a constant supply of oxygen, glucose, and essential nutrients to function properly. It is logical then that poor circulation would reduce blood supply, which would impair cell function. This can occur either in the major arteries of the lower extremity or at the capillary level of microcirculation. An essential component for proper microcirculation is an adequate supply of nitric oxide, which we will discuss shortly. Peripheral artery disease, or PAD for short, affects over 12 million Americans, with many more being undiagnosed, as in the early stages there are no symptoms. It occurs when there is a plaque buildup in the arteries of the lower extremity. If this has happened, you can bet that the circulation at the capillary level is also impaired. Patients with PAD have leg pain, cramping, and aching, made worse by walking and better by rest. There will be an elevation of certain lab tests, including C-reactive protein, fibrinogen, and homocysteine. It is doubtful that you have had any of these tested previously. Of course, we test them all. PAD is most common in diabetics and smokers. If you are a smoker who is also diabetic, chances are that you have PAD and poor microcirculation. The end result of severe PAD is ulcers, followed by amputations. Our treatment focuses on improving circulation to prevent this. So how do you know if PAD may be causing or contributing to your peripheral neuropathy? Unfortunately, there are many millions of people who don't know they have it, as in the early stages there are no symptoms, as the blood supply has not yet been reduced enough to cause problems. If you have aching, pain, or cramping while walking that gets better with rest, you probably have PAD. We check for PAD in office by checking the pulses in your ankles. We also check your nitric oxide levels and perform a simple neurological test called the Sens-Weinstein monofilament test. This test has been shown to be highly accurate in predicting future foot ulcers in patients with peripheral neuropathy. We may send you out for additional studies of circulation as well. Impairment of microcirculation is the ultimate cause of many cases of peripheral neuropathy, as this is where transfer of essential nutrients, oxygen, and sugar from blood to the cells occurs. Additionally, poor microcirculation will reduce the ability to remove toxins that accumulate as a result of normal metabolism. These toxins damage small nerve endings. Improving microcirculation plays a huge role in our comprehensive treatment program. I will talk about this further in the section devoted to our treatment protocols. Diabetes is the single most common cause of peripheral neuropathy. About 50% of all peripheral neuropathy can be attributed to diabetes. You don't even have to be diabetic to get peripheral neuropathy. Pre-diabetes is now also recognized as a cause. Most patients with pre-diabetic peripheral neuropathy are obese, have insulin resistance, high cholesterol, and triglycerides, and blood pressure. The earliest sign of peripheral neuropathy in many people is impaired glucose metabolism, yet your doctor has probably never run the correct test to see if you have glucose dysregulation, which is why we check your insulin levels as well as glucose and HbA1c. With the current standard treatment protocols, up to 4% of diabetics develop foot ulcerations each year. Almost all have peripheral neuropathy and severely impaired circulation. Diabetic ulcers can lead to over 40,000 amputations per year, and up to 80% of amputees die within 5 years. I will show you that with our comprehensive treatment protocol, you can improve your glucose control and microcirculation, something no other doctor has told you is possible. A vastly underappreciated cause of many nerve disorders is due to the body mounting an immune response to gluten and gliadin, proteins found in wheat and other grains. Most people think that celiac disease is the only problem caused by gluten. Totally untrue. By far the most common types of reactions that occur are nerve-related in nature, and they can occur without any gut involvement. Peripheral neuropathy is the most common nerve condition caused by gluten. A recent study showed that patients with neurological disease had a much higher incidence of antibodies against gliadin than did asymptomatic controls. This study showed that 40% of people who had peripheral neuropathy of an unknown cause had antibodies against gluten. Were you told your peripheral neuropathy is idiopathic? I bet your doctor never checked you for gluten sensitivity. Inflammation is a major cause of virtually all chronic conditions. Acute inflammation is how the body deals with infections. This works through immune mechanisms and is the ultimate endpoint for normal immune responses. Redness, swelling, fever, and pain are the hallmarks of inflammation. It is when the normal inflammatory response becomes chronic that problems occur. Chronic inflammation sets up a vicious cycle of events that leads to disease. Inflammation of nerves leads to damage, which can contribute to, cause, and perpetuate peripheral neuropathy. We test for several markers of inflammation. C-reactive protein is one marker of inflammation we check. It normally elevates during any acute infection and acts to enhance the immune response. It peaks within 48 hours, then declines. It is when C-reactive protein is elevated without an acute infection being present that there is a problem. It tells us that there is a chronic inflammatory condition going on. This is important to us because peripheral neuropathy is an inflammatory condition, as are peripheral artery disease and diabetes. These conditions often elevate C-reactive protein. Not only is C-reactive protein a lab marker for inflammation, it is a direct cause of peripheral artery disease. It binds to the walls of blood vessels, promoting cell death. It is found with oxidized LDL in atherosclerotic plaque. It stimulates the production of other chemicals that further damage the small capillary cell walls. It inhibits the breakdown of chemicals that they themselves break down clots and plaque. And extremely importantly, it inhibits the production of endothelial nitric oxide, which we will discuss in depth in the treatment section of this lecture. There are a number of metabolic causes or contributors to peripheral neuropathy, including mitochondriopathies, oxidative damage, and vitamin deficiencies. Often, they all exist together. Mitochondria are small organelles inside each and every cell of your body. They produce the vast majority of energy that runs all of your bodily functions. When they don't perform normally, you don't either, so you have a mitochondriopathy. The two major reasons this develops are vitamin and mineral deficiencies and oxidative damage to the mitochondrial DNA. Damage to DNA is due to chronic inflammation, which in turn is due to diabetes and oxidative damage, among other things. Hopefully, you're beginning to see and appreciate the interconnectedness of many of the reasons for developing peripheral neuropathy. Unless one considers all contributing causes, treatment cannot be successful. As we discussed previously, peripheral neuropathy tends to affect the longest nerves first, which are located in the feet and toes. One reason for this may be because the mitochondria are made in the body of the cell, which is 3 to 4 feet away from the terminal nerve endings. The mitochondria have to travel the entire length of the cell, called the axon, which takes 2 to 3 years. Nerve mitochondria live much longer than those in other cells, so in their journey they may accumulate damage to DNA, making them not only poor generators of energy, but now excellent generators of free radicals, which in turn cause oxidative damage and inflammation. This creates a vicious cycle, as it is essential nutrient deficiency, oxidative damage, and inflammation that led to damage to the mitochondrial DNA in the first place. Oxidation from free radical formation, as we have seen, plays a major role in damaging mitochondria. Many vitamins and minerals act as antioxidants. Proper mitochondrial function is dependent on almost 20 different essential nutrients, so deficiency of even one can impair normal mitochondrial function. Optimal levels of all vitamins, minerals, essential fatty acids, and amino acids provide the most favorable environment for cell repair to occur. Normal conduction of nerve signals demands that the nerve cell membrane function properly. Yet this is the part of the cell most likely to be damaged by essential fatty acid or phospholipid deficiency. Deficiency of several vitamins is a direct cause of peripheral neuropathy. Naturally, we check for essential nutrient deficiency, and our program provides optimal essential nutrient support to enhance nerve cell regeneration. Vitamin D plays a key role in peripheral neuropathy, so of course we test your levels and supplement it as part of the nutraceutical portion of our treatment protocol. Up to 70% of Americans have low levels. Deficiency is associated with peripheral neuropathy symptoms and has been found to be an independent risk factor for developing diabetic peripheral neuropathy. Recent studies have shown improvement in pain and depression in diabetic peripheral neuropathy with vitamin D supplementation. Even more exciting is a study showing that vitamin D dramatically improves repair and function in experimentally damaged nerves. Oxidation is a chemical reaction that is essential to life. As with the immune system, things can go wrong, leading to oxidative damage. It is the same reaction that occurs when iron rusts. Obviously, rusted iron, if bad enough, causes irreparable damage. Chemicals called free radicals cause oxidative damage or body rust. They run amok, creating all kinds of havoc if not held in check. With the help of several antioxidant nutrients, the body has several enzyme systems called glutathione, superoxide dismutase, and catalase that neutralize free radicals. Left unchecked, free radicals impair function, causing inflammation. They are a major cause of most chronic diseases, including peripheral neuropathy. Our program is designed to reduce oxidative damage and free radicals. A variety of toxins contribute to or can cause peripheral neuropathy, perhaps best known as peripheral neuropathy from alcohol overuse. Heavy metals, including arsenic, lead, and mercury, also damage nerves at low levels. That is why we check for them. Peripheral neuropathy is a common side effect of chemotherapy. Perhaps the least appreciated, least known, especially by doctors who prescribe them, and certainly least talked about, is that common medications can cause peripheral neuropathy. A host of chemotherapy medications cause peripheral neuropathy in up to 30% of people taking them. What is especially troubling is that recent research shows that metformin and statin drugs, which form the cornerstones of diabetes treatment, can actually directly cause peripheral neuropathy. Metformin increases a chemical called homocysteine, a very nasty little chemical that causes small blood vessel dysfunction, leading to reduced microcirculation by reducing nitric oxide and increasing oxidative damage. It also inhibits the absorption of members of the vitamin B complex. Deficiencies of B6, folate, and B12 are known causes of peripheral neuropathy. In one study, 40% of people who used metformin for over 6 months had low vitamin B12 levels, and 75% of these people had peripheral neuropathy. So metformin may cause or contribute to peripheral neuropathy in up to 30% of long-term users. Of course, we check for homocysteine and all vitamin B deficiencies in our program. A class of drugs called statins are the most commonly prescribed class of medication. Drugs like Crestor, Lipitor, and Zocor account for over $15 billion in annual sales, but the drug companies aren't happy with that, so new guidelines issued from your friends at the AMA, if implemented, would double sales. Unfortunately, statins have recently come under fire. Liver damage in long-term users is showing up. A well-known side effect is acute muscle damage and death. Insomnia, erectile dysfunction, and increased risk of cancer are additional side effects. Since 50% of peripheral neuropathy sufferers are diabetic, improving diabetes is a critical component of treatment. Unfortunately, recent research shows that simvastatin, found in Zocor, actually increases the risk of developing insulin resistance in non-diabetics, which leads to diabetes. An analysis of 72 studies involving 159,000 patients concluded that statins as a class significantly increase the risk for developing diabetes by 9%. What is not on the radar of your primary care provider is the fact that statins can cause peripheral neuropathy. Statin users are 4 times more likely to develop peripheral neuropathy than non-statin users. If you already have peripheral neuropathy, you are 16 times more likely to be a statin user. One study concludes that up to 10% of long-term statin users may develop peripheral neuropathy. I'm not advocating that you immediately discontinue metformin and statins, but if there is a correlation of the onset of peripheral neuropathy with these drugs, one may wish to reevaluate the risk-to-benefit ratio and discuss a trial discontinuation with your primary care provider. We have spent quite some time discussing the various causes of peripheral neuropathy. Unfortunately, there is little that your medical practitioner has to offer, and certainly nothing that will significantly alleviate your symptoms, repair damaged nerves, or increase the density of nerve fibers. Gabapentin, Lyrica, and various antidepressant medications are all used with some benefit and side effects that force many to discontinue their use. It is reasonable to assume that if you had received satisfactory results from treatment to date, you would not be here. So there is little point in dwelling on failed therapies. Instead, let's discuss how we may benefit you and the research-based clinical rationale for our protocols. Albert Einstein said, "The definition of insanity is repeating the same thing over and over and expecting a different result." H.L. Mencken said, "For every complex problem, there is an answer that is simple and wrong." So logic dictates that a new, comprehensive solution is needed to treat a complex problem. While drugs may improve your pain, they do nothing to address the root causes of your condition. First, through a thorough history, set of questions, and neurological examination, we must confirm that you have peripheral neuropathy of the type we may be able to help you with. Next, we need to determine the root causes of why you developed this condition. Next, we must address all those causes through specific treatments directed at each cause. Finally, therapies both in office and at home are needed that will start to regenerate your nerves. So how do we accomplish this? After reviewing all of your lab tests that I discussed previously, we will provide specific, non-drug-based treatment with proven nutraceuticals to address each abnormal lab value. This will be individualized to your personal condition. Keys will be to treat autoimmune conditions, blood sugar dysregulation, poor microcirculation, hypothyroidism, gluten sensitivity, inflammation, oxidative stress, essential nutrient deficiencies, and toxins. Since this will be a multifaceted treatment program, it is important at this point for you to understand that it is also one in which you must play a critical active role. If you are unwilling or unable to participate in your recovery, stop listening now, as we will be unable to assist you. We are responsible to you for providing state-of-the-art evaluation, diagnosis, and treatment, but we are not responsible for you. Your responsibilities will include dietary modifications, a home treatment program, taking the recommended nutraceuticals, and wearing special foot insoles. In-office therapy will be 3 times per week and will consist of 30 minutes of MIRE therapy, M-I-R-E therapy, which I will discuss in detail, coupled with vibration sessions, plus once per week manual therapy with acupuncture if indicated. So what are these therapies and what's the proof they work? Our primary in-office treatment is with MIRE, which stands for monochromatic infrared energy. This is a pain-free treatment that is research proven to reduce pain, improve microcirculation, and help regenerate peripheral nerves in a large percentage of people affected. Vibration therapy acts to stimulate the production of nitric oxide, which acts to improve microcirculation. In a study of 375 patients with diabetic peripheral neuropathy, wearing static electromagnetic insoles for 4 months significantly decreased pain, numbness, and tingling between 10 and 32%. Obviously, you're going to want to know if MIRE therapy is effective. The initial research was actually done at the beginning of the century using low-level laser light therapy. This was far less effective than the current state-of-the-art LED therapy due to the very low energy output over a small area compared with today's equipment. So results with less sophisticated equipment bodes well for current generation equipment. There is a large body of research showing the benefits of MIRE therapy, Let's review some of them. In a large 2006 study involving 493 patients with an average age of 72, 50% of whom were diabetic and 50% had peripheral neuropathy from other causes, the beginning reported pain level on a 0 to 10 scale was 6.9 for both groups. After 12 30-minute treatments with MIR, average pain levels were reduced to 2.5. Our program is 24 30-minute treatments with MIR therapy. A 2006 study on 269 patients of average age 69 years concluded that 18 MIR treatments resulted in a 38% decrease in pain and 77% improvement in sensory impairment. They concluded that preliminary findings suggest that MIR plus manual physical therapy improves pain, balance, and sensation symptoms in patients with peripheral neuropathy. Our program consists of 24 visits 3 times per week for 8 weeks. In 2003, it was thought that diabetic peripheral neuropathy was irreversible and progressive. This study using MIR on 18 patients for only 6 to 12 visits proved otherwise, as it showed decreased pain, improved balance, and sensation in the feet. In a 2000 study, the effect of low-level light therapy on vascular smooth muscle cells concluded that low-level light therapy caused potent dilation, which led to marked increases in arterial blood flow with involvement of nitric oxide in the early phase. A second 2012 study concluded that a 30-minute MIR produced a significantly greater increase in the capillary blood velocity and superficial skin blood flow than in the placebo group. Several studies used MIR to reduce inflammation. They concluded that infrared therapy inhibits inflammatory chemicals called cytokines, increased muscle endurance, accelerated wound healing, and reduced oxidative damage. Just as plants have photoreceptors that absorb light and transform it into energy, so do humans, in an evolutionarily similar process in organelles called mitochondria. An enzyme at the center of this process, when stimulated by infrared light, causes an increased energy production. The end result is an increase in healing, obviously necessary to rebuild nerves damaged by peripheral neuropathy. Improve mitochondrial function by providing all of the essential nutrients required for energy production is critical to optimizing results from MIR therapy, which is therefore why we provide you with optimal mitochondrial support. The most important question is, what is the effect of MIR on peripheral neuropathy? A recent study used rabbits as test subjects. The scientists cut the perineal nerve and then treated it with infrared light. They concluded this study establishes that infrared light with optimized parameters promotes accelerated nerve regeneration and improved functional recovery in a surgically repaired peripheral nerve. A large 2005 study on 252 patients, average age 76, all with diabetic peripheral neuropathy, found that MIR therapy reversed diabetic peripheral neuropathy, significantly decreased falls, and increased activities of daily living, with benefit continuing even after 1 year with continued home use of MIR. Yet another study on 49 consecutive diabetic peripheral neuropathy patients showed that after 12 visits with MIR, all 49 had improved sensation in their feet. Here is a photomicrograph of normal epidermal or skin nerve fiber density. The nerves have been stained so you can see them. Notice the number of fibers and that they reach all the way to the top layer of the skin. Compare this with the reduced number of nerve fibers seen in someone with peripheral neuropathy. Notice there are fewer fibers and that they no longer travel to the surface of the skin. This is a hallmark of peripheral neuropathy. Here is a slide of a small 3 mm skin biopsy of a patient before and after treatment. The picture on the left shows the decrease in nerve fiber density and their failure to extend to the top layer of skin, which is typical of peripheral neuropathy. On the right, 6 months after treatment with MIR, see the increase in the number of fibers. You can also see very small fibers going all the way to the top of the skin. This shows that MIR therapy is effective at regenerating damaged nerves from peripheral neuropathy. Hopefully I have given you a better understanding of exactly what peripheral neuropathy is. The next step is to take your history and perform an exam to correctly diagnose your condition and to determine if you are a candidate for a comprehensive treatment protocol. You should have a better understanding of the multiple causes of peripheral neuropathy and why we perform extensive lab studies to rule in or out many of those causes. You should also realize that there is real hope for your condition and that with a complete program in which you are an active participant, you may be able to greatly improve your quality of life. Let's get started. I will be in with you momentarily. Thanks for listening.